try not to make it formal with a lot of slides. I'm gonna go through some slides, but I'm only gonna talk, and then you can ask some questions if I can hear you. I'm trying to get to hear everybody, but I'm actually gonna go through some slides and talk and see how everything's going. Okay, so let's start first. And let me change this grid. Okay. We're going to start first. We're going to talk about diabetes, heart disease, strokes. And what's most dear to me, I'm a cardiologist, but I'm also a vascular biologist, and I'm also a vein guy. So now we're doing vein work a lot more than we're doing lots of cardiology. But cardiology is still dear to me in my heart. And one of the things that we had to talk about with cardiology, we always got to talk about diabetes and stroke. And what's most dear to me is your stroke risk. Now, my biggest fear is not dying. We're all going to die. But my biggest fear is strokes. Because what strokes is the biggest fear is because it leads to you losing your independence. And your independence is the most important thing you have going for you is your independence. And once you lose your independence, it's really tough. So that's why I'm going to link in diabetes, heart disease, and strokes. And then I'm going to give you some recommendations at the end of the talk, since this is Heart Month, and there's some things that you can get done, everybody can get done, and see how that works. And one of the things it is this we're talking about is really we're going to talk about the scans, a CT scan to see of your calcium scores at the end and how that works and how we can stay healthy. All right. So let's go through some quick slides and we'll get everything together. First is it's talking about the interactions of genes and most of our stuff is we have risk factors, but we also have genetic things that we can't control. That we can't control who our parents were. We can't control that we have a history of diabetes. You may not get diabetes yet, but if you have one first degree relative with it, you have a 50% chance of getting diabetes. So it's really high risk, and it puts you at over more risk than anything else to get more heart disease. Now, let me go through a couple things. I'm not going to spend much time on the genetics, even though I am a genetics guy. It's that 65% of all deaths from are usually diabetics die is from heart disease. So if you're diabetic, you're at a high risk, and you're high risk for heart attacks and strokes, but more premature ones at that. Now, other facts is 6%, and you realize now we're in the South, and of course, in the South, we're in the Bible Belt, the Fat Belt, and the Stroke Belt. We like to eat and we like to talk about Bibles, but we all have high blood pressure and diabetes too. And it's really endemic to this area about the diabetes and the heart disease and the stroke risk. Now, diabetes is a metabolism disorder, and you can get it from genetics, but you can also acquire diabetes. Of course, it's dealing with the pancreas, and most people are type 2 diabetics when we get older. But the type 2 diabetics means we have an insulin resistance. And the insulin resistance, unfortunately, also causes a lot of other problems. And one of the big problems insulin resistance does, it makes you hold on to weight, especially weight around your waistlines and your thighs. So what happens is the insulin that you have is not working properly. So it's not pushing the cells, and it stimulates and generates fat cells around your abdomen and in your thighs. I'm a vascular biologist, and what it does to the actual proteins, it stimulates some of the proteins, actually stimulates some of the proteins to get more clotting and less declotting. So that's one of the things that it does. So really, you got to be real careful. Here's a couple slides with his pancreas. And most people think that when you think about diabetes, some people think, well, it's just that it's genetics. Well, you can acquire it too from viral infections. The virus can affect the pancreas and affect the islet cells and make you be a diabetic. And that's what happened to one of my nieces at a young age. We don't have juvenile diabetes in our family, but she ended up with mono. And after with mono, her liver and her pancreas stopped working. So she was on diabetes medicines for at least insulin for 6 years, and then it gradually got better. So it's not just that it's just genetics, but you can acquire it too. Couple things about it. Well, I was telling you, it's the glucose handling, and it makes you at decreased risk for healing. So you get ulcers and everything else, but it also makes a lot of other things with the clotting factors wrong. Here's what the diabetes affects. It can affect your eyes. I tell people if you're diabetic, most people don't know it. And by the time they know it for type 2, they probably have had it for 4 or 5 years. And you just haven't been able to tell that you had it. So most people just get some different feelings. Some people get a little sweaty. Some people can tell when their sugar drops, but it's improper handling of it. And if you do have diabetes, you got to watch for your eyes. In 10 years, most people have eye problems with diabetes. 20 years, everybody has kidney problems with the diabetes. And then, of course, you get the neuropathy also with it. And the neuropathy can not only be with the legs and your fingers, but you get the neuropathy associated with the stomach, and that's what you get, gastroparesis. So a lot of people suffer from that, and it's a really bad thing. It's one of the bad problems. And here's a picture of the blood vessels, increased risk for the blood vessel. Here's the eyes where you get neoproliferation in the vessels to your eyes. So all diabetics have to be checked at least once a year to make sure they don't get this. And this is a common and frequent form of some of them losing their eyesight and their vision. It's from the diabetes. It's just new blood vessels that form and they leak and they close up the eye vessels. So even if you're seeing a primary care doctor, and if you're diabetic, even your primary care doctor needs to look at your eyes, but you need to have a specialist see at least once a year to make sure you're not getting this retinopathy that does occur. And it's a bad thing. A couple other things is this thing we're talking about, pre-diabetes. Now we don't even consider it pre-diabetes. It's you're a diabetic or you're not a diabetic. And you're the ones that require medicine or don't require medicines, and you can control it with diet and stuff. And it really does help. The exercise and diet. The key thing is the exercise help push the impaired insulin into the cells and make them work better. Most people went with the metformin at first, and the reason why the metformin, because it helped the receptors pull in some of this insulin. And you need the insulin pulled in to keep the weight and the weight and everything down from the stomach. But that's why, and I have a couple patients I tell all the time is that you got to drink a lot of water. Remember, if you get sick and you're diabetic, what we do when you come to the hospital, we give you saline water. And what's the saline water for? Is to dilute your sugar. And once you dilute the sugar, it gets much better. And so that's why I tell people, some of the diabetics, I say, if you want a piece of cake, eat some, just don't overindulge. And what you want to do is you got to chase it with water and dilute it. Because of that high concentrated thing. And also the guys that exercise, you need water too, even while you're exercising. In the past, people say, let me just exercise, not drink. But you really have to drink water, and it helps dilute and make things a lot better. So that's why I tell people with the diabetes, it's not all about the weight loss. And you got some very thin people that have diabetes. So it's just not really all about the weight loss. It's all about protecting the inner organs. And so there's a connection between diabetes, heart disease, and strokes. So let me tell you about some more connections. Oh, it's really, 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 really important that most people have to get a lot better control of their diabetes and try to help it. And some people get gestational diabetes. But for the most part, for most women, they are protected from coronary artery disease with the hormonal thing. And it's a hard thing we have to teeter out. Unless you're a menopausal woman, it's rare for us to see heart disease or even strokes in premenopausal women. The problem is we haven't been able to pan that in our studies. We looked at several studies. We did the HERS studies and the heart studies, and we haven't been able to find out exactly what the hormones do. We found that it made people worse if we gave people some hormones. They had increased risk of clots, you had other problems, but we do know it's a protective effect. Women's heart disease risk is much lower than men until menopause. Then after menopause, it goes up even faster than men at a higher rate and higher risk. The problem we have with that is that a lot of women with heart disease present differently. And as you get older, you present differently. You won't have the classical symptoms, elephant sitting on your chest, pressure. Some people just have shoulder pain, little neck pain, or jaw pain. The key thing that we're going to see in a couple of these slides is that if the symptoms keep recurring with more activities, you still have to be seen. And most people don't go by the recipe. There's a cookbook recipe people think is pressure on my chest and that's what happened. No, sometimes it's just fatigue. And as you get older, some people do not have chest pains. So if you start seeing a change of symptoms and you start seeing you get more short of breath, we still need to be evaluated. And lots of people, I've had one of my relatives came to me, that the first thing the doctors told her is maybe it's your nerves, maybe you're stressed. And that's one of the problems we have. We have a lot of women getting blowed off of their symptoms because they think it's anxiety. And true enough, mental health disease is really on the rise, especially with the COVID things. But you still have to take this serious because we have people, like I tell people all the time, I said, I have people that have these symptoms. They said, let me sleep on it. And I tell people, you might be lucky enough to wake up. And if you do wake up in the midst of a heart attack, you're going to feel like you're unlucky because now you got heart failure because we can't do anything about it after so many hours of the treatments and stuff. So we really have to really notice and look, we have to do a little bit better with our training of some of the young docs because they always like to think in categories, in boxes, and people aren't boxes and categories. There's a lot of differences and stuff. Let me tell you, this is another slide with the high blood vessel and how it affects the heart. But this is what we're really talking about atherosclerosis. And I'm going to tell you 3 good hints that people have to worry about. This is what a normal artery looks like. And there's the endothelial linings right up here. And that's one of the most hot topics that we're talking about now is the endothelial lining of the blood vessels. But what we found out is even young kids have what we call a fatty streak, and that's the lipid layer. And it's not a big fatty streak like this, but it's a little fatty streak. So they're predisposed to blockages. And the big study was about before whether if you got a blockage in your leg, now do you have blockage in your heart? And most of the times we say, yes, you have to think about it that way. But we now know one of the most important things is stabilizing this lipid deposit in your vessels. And so how do you stabilize this plaque? And that's usually with cholesterol medicines. We found that and that's why I just got finished talking to a couple of my buddies a few minutes ago, is that it's the most prescribed drug, but it's the most non-compliant drug. And if you look at it, it's only 40% of people that take their statins and get their refills on their statins like they're supposed to. But really what that does, it helps stabilizes the plaque and makes it less likely to rupture. And that's where the problem comes in plaque rupture. See, and this is the plaque. And see, this is the plaque. When you see this, most people look at this and they say, well, this is probably like a 20, 30% blockage. Just about everybody has 20, 30% blockages. Yeah, you do, but you want to stabilize it. And what the problem is whether it be a force, whether it be high blood pressure, stress, the plaque ruptures and it closes off the vessels. Most people used to think that most of the people having heart attacks were people that had 80, 90% blockage. It's not. It's the people with 40 and 50% blockages. It's where the plaque ruptures. You don't have to have significant obstructive disease for that to happen. And here also was my biggest pet peeve is the strokes. So what's the risk factors for heart disease and strokes? In diabetics, there's a lot of risk factors. But the risk factors is if you combine diabetes with hypertension, it makes it even worse. And that's a worse number for your kidneys and on your eyes. But it also is more likely for the plaque to rupture. And that's what you got to watch out for is plaque rupturing. Couple things. And here's a little funny picture of this little kid there thinking family history, but he's got smoking a cigarette and drinking a Coca-Cola. And when you think about it, this is what I had come into my office the other day. A guy smoking, smelled so bad of his smoke and everything. And he ended up having a complete occlusion of his leg. And I told him, I said, wait a minute. And I saw him 6 weeks ago, his pulses were good, but 6 weeks later, his leg was messed up. So these are the risk factors you have to watch about. I mean, some of them you can't control, like the family history. If you have a first degree relative with, especially your dad, more than the mom, with a heart attack before the age of 55, that puts you at high risk. You automatically deemed at high risk with that. And what we do for lots of people with that, sometimes we start exploring and looking for other risk factors happening. The central obesity that usually I told you occurs, some of it's genetics, but remember, some of the central obesity comes from the diabetes. And there's a lot of people out there that are type 2 diabetics that don't know it. And then some of it's also genetic too. And that's just the abnormal building of the fat. But the other thing is the high blood pressure. And this is one of my pet peeves about high blood pressure. I do lots of talks on blood pressure because blood pressure, unfortunately, is a silent killer. No one knows their blood pressure is high until they have under stress. And so I tell people, even while we're doing stress studies, it's normal for your blood pressure to go up during stress. The problem is when it gets outside of the normal range or it gets to the hypernormal range with little stress, that means your blood pressure really wasn't controlled in the first place. So you really have to control the blood pressure. But the problem is no one feels blood pressure. If your blood pressure has been high for a long period of time, You can't tell it's high. Only time you'll know it then is when it drops. When it drops, you have the lightheadedness, the dizzy symptoms, because no one checks their blood pressure regularly. And so when you do go to the doctor's office, they should have it checked. Now, I actually been telling lots of patients to have a blood pressure cuff at home. And sometimes it's good, sometimes it's bad, because they call me about 5 or 6 times a day and say, hey, what is it now? But I tell you, the normal response is for it to go up when you're under some stress. The problem is, if you ever get a blood pressure over 190, that's not a normal response. Even if you're stressed, if it's 190, it's not a normal response. That means your normal blood pressure is above what it's supposed to be. And if the stress stays higher, it keeps going. The smoking is it's nothing really to talk about. It's really bad. I tell most of my guys that smoke, I tell you, look, I try to get you from stop smoking, but it's a tough thing, especially when you're under stress. The key you got to find out is why somebody's smoking. Some people like the taste. It's hard to stop if you like the taste. It makes your coffee taste better. It makes the food taste better. And some people it's from the stress, but you got to get the stress better. But what happens is you might escape cancer, you might escape emphysema, you might even escape a heart attack. But what they never escape is peripheral vascular disease. The reason why you'll never escape peripheral vascular disease because your blood vessels, just the way they are, they taper to small blood vessels over after you pass your knee. And what you have is 3 small arteries. So if you close one of them off, no one tells. You can't even tell if that one's closed off. You just keep doing what you're doing. But when the second one closes off, then what you get is you get this thing called claudication. You start having cramps, the legs start getting fatigued. The problem really occurs is when the third one closes off. And when the third one closes off, now you start getting cold extremities, bluish color extremities. And if you do have any cuts, that's when they lose the extremities. So that's why I tell people the worst thing you can do for me is just smoke and stuff. And that's where it really gets, but you might escape some of it, but you'll never escape the peripheral vascular disease. It's just the way it is. And so that's why I tell people encourage them to stop. But you have to be mindful that it's kind of hard to stop, especially when you're under lots of stress. Okay, now a couple things. The family history, you won't be able to escape that. That's all in your genetics. You remember, like I was telling you before, age 55 for men, age 65 for women. Remember, that's the classical symptom is a crushing sensation in your chest. Most people don't have that. That's what we're always taught, but it doesn't have it. Here's the central obesity. It's tough to work on the central obesity. It's very, very hard. When it gets to be abnormal, and what we do with the central obesity, we use your hip to waist ratio is more important than that. But the central obesity, because you're just holding on, and it's usually a sign also, this thing we call syndrome X is with the diabetes, the high blood pressure, and then it leads to other worsening heart problems. So I was looking at Dr. Sanjay Gupta's book, and one of his things is, how do you keep yourself sharp? And how do you keep yourself sharp? Just exercise, but you also got to get a proper rest, and we also have to eat right. And it's kind of hard when stress and other things are going on to do all 3 of those things, but it's really tough. But here again, here's the central obesity I was telling you about. Waist measurement more than 40 for men, for women more than 35. I tell people if you're a guy, if you're wearing oversized 40 pants, you're in trouble. So I tell them to try to get into a 38, and then we'll feel a little more comfortable. You don't have to drop a two pant size, but 38 is better. Anything over 40 is tough, and it's very, very bad. And that's where the obesity comes in. Remember, it's all here, and some of it, my wife tells me mine's just because the way it stands. But I said no, it's just the stomach, and that's what it is, and it's really tough. But you really got to work on trying to get that down and working on some of the core to help get the stomach muscles down. But here again, the high triglycerides, the high blood pressure, the HDL is low. The LDL, which we're going to talk about in a second, is the cholesterol, which I firmly believe is the 2 best things you can ever do is take cholesterol medicines and exercise. And I'll show you that in a second why that's the best thing you can do. Some people can't tolerate cholesterol medicines, though. I have to tell you that. So I've tried 5 of them, and the 5th one worked best for me. The first one made my hair fall out. So, and that's not a good thing with the hair fall out. So I told one of the reps for one of the drugs that made my hair fall out, I said, hey, my hair falling out. He said, oh, you're just talking. I said, no, I wouldn't read the package insert. And I tell most of the patients, if you read the package insert, you're going to get them symptoms. But unfortunately, you have to. Everybody's symptoms different. Everybody's built different. And what I mean by that is, Anybody can have a side effect to any drug. You just have to see. And that's why even if you have seen a doctor, a new doctor, you really don't want to start two things at the same time because you won't know what is causing the problem. Drugs interact and there are side effects. And so I told the guy I was taking this cholesterol medicine for about a month or two, and all of a sudden the hair started falling down the side. And I went to my barber and he said, "Oh, you got alopecia." I said, "Thank you. I already knew I had that." And so I asked my wife, she said, Where you been sleeping at? Where's your hat? You been putting a bad hat on?" I said, "No, it's not that." And the problem was, if it was falling out on the top, I could understand, but it was falling out on the side. And that's just not a natural spot for your hair. You lose hairs on the side. And what it was the cholesterol medicine. So I stopped the cholesterol medicine for 4 weeks and my hair started growing back. So I told him, I said, "Hey, look, it's the cholesterol medicine." And this is what I tell for most of our patients. If you have a little effect with it, stop it, let it wash out your system, see if the symptoms get better. Unfortunately, you can't do that when you're taking 3 or 4 different new medicines at the same time. You won't be able to tell. And if you are taking 3 or 4 medicines, then you just have to gradually eliminate one at a time to see which one is causing the side effects. There's a lot of interactions, and that's what we see. But the bad cholesterol is where it's at now. And what we talk about is the bad cholesterol is the LDL. And I'll show you that. And there's a couple things, because we went all around the spectrum with this LDL and stuff before. And one of the things we went and had was we first thought it was low HDL that was causing problems. And then we said, no, it's the triglycerides that's causing problems. And other than we said it's the total cholesterol. So when I asked somebody and they come to see me, they say, "Oh, my cholesterol is good." I said, "Okay, what does good mean?" "Oh, about 250. I said, "Well, that's really not good." What you really want to know is what your good cholesterol is and what your bad cholesterol. But now what the new focus is really on the bad cholesterol. And with the bad cholesterol is what we call the LDL. And that's the one that has been shown to make most of the deposits in those plaques that you see. So you really want your LDL. And if you do have risk factors, one risk factor, we want your LDL to be under 100. But if someone that has known coronary artery disease or you're diabetic, we want that bad cholesterol to be under 70. And what is a good total cholesterol? Well, most of the time we say we don't really mind, but if you see somebody with a total cholesterol of under 140, 150, their cholesterol usually is good. We don't use 200 anymore. We use what the bad cholesterol is. But if you see a total cholesterol about 150, you're in good shape. And still then, if you're diabetic, you still need to be on a statin. And just to stabilize the walls and maybe make the plaque better. And I'll show you in the end what some of the studies have shown is that you can actually get plaque regression. They've done a couple studies where someone had like 60% plaque in the vessel, exercise, and then taking a statin, it came down to about 20, 30%. And if you keep going, and if you get that bad cholesterol under 70, you can turn your blood vessels to where they look almost like teenager blood vessels. So it's been shown and shown again. And how can you tell when you go to the doctor's office? Well, some guys do carotid ultrasounds. And when I have a bad smoker and I want to prove to them how bad things is, they look and see this big old plaque sit up in their neck. And I say, yeah, this is what it is. And what happens is if the plaque breaks off, you have a stroke. And if it completely closes off, it's a major stroke. So that's what really gets a lot of people attention when they see it. And some of them really awful. You can see how bad the arteries really are. And here's the category of the cholesterols, what we were talking about before, LDL. But remember, now our goal is under 100 if one risk factor, but if you have diabetes, we want that number to be under 70. And the question we was asking is, how low is too low? Well, you need cholesterol for you to make the healthiness of your cells. So you need some. So what I do is I usually push people, but I don't like to see the LDL under 40. If it's under 40, I start backing off some of the medicines. And I have to tell you about 2 studies right before we finish, which has panned out. This is one of those little things that I tell people to have. And I've been fussing at my relatives this past week because I had 2 of them that had problems. But the problems I was telling them is that we have to be a little more aggressive in our care. Some docs don't like you to ask questions, but your goal is you have to do your homework even before you go to the doc. So you need to have a list of questions because it gets in there and things get all combobulated. And some guys see you throw the stethoscope on you, and before you can say, hey, bye, they're walking out the door. That's when you have to stop people. You have to have, excuse me, sir, can you answer at least one or two questions for me? And then you got to get your questions in. Because some people aren't really great teachers and they'll get pushed for the time with the insurance and want to see volumes and stuff. But you really got to get your questions answered. It's a shame because sometimes you walk out the office and you don't even know what you were talking about and they don't know what he said. All you know, he wanted to put you on a new drug. And you say, okay. So you want to have some questions and see. There's good things and bad things about Google Doctor. The Google Doctor is good because it puts you in the range, but it also should pique you to ask the questions. And if you get a doctor that doesn't want to ask the questions, we might have to look for a different doctor because they should be receptive to asking questions. And my other pet peeve about doctors too is, and I love docs, but I actually am a proponent of people saying, hey, look, you just got to be honest and say, hey, I don't know the answer to that and I can get back to you. But if you don't feel like you're getting satisfaction on your questions and your answers, seek a second opinion. Some doctors get highly offended if you seek a second opinion, but they shouldn't because it's a check on their ability. If the second opinion is saying the same thing you're saying, you said, okay, I got the second opinion. But it's never any harm in getting a second opinion, especially if you're going to go through a very life-threatening or a procedure that you're not sure about. Always get a second opinion. And it's always a good thing. Sometimes people will give a second opinion in the doctors in their office, or some guys will get upset. You just have to seek and find your own second opinion. And it's always a good thing. For us as doctors, though, to me, it's a test that we're all on the same page. You can skin a cat differently, but you're on the same page and you still do that. And you should always consider that. Blood pressure. Oh, now everybody says, what's the normal blood pressure? It depends on your risk factors. If you're diabetic, the blood pressure they really push for is under 110, the systolic blood pressure. The bottom blood pressure is the diastolic. We want that to be around 70. What is bad blood pressures? Well, we consider high blood pressures in the 160s, the 140 range is high. When it's above 160 to 200, it's extremely high. And if it's around that range, if you're having symptoms, that's what we deem hypertensive urgency. So it means it's urgent that you got to get treated. Most people do not treat a single blood pressure. So if you come in once and your blood pressure is a little high, the rule is you shouldn't treat it unless it's extreme on the extreme ends. But what you should do is have them recheck the blood pressure when they're not stressed. And there's this thing called the white coat phenomenon. I rarely wear my white coat, but it's the white coat phenomenon. As soon as you go to the doctor's office, your blood pressure shoots up because you're afraid he's going to find something. And sometimes they do. But you really have to check it and even check it at home. Some of those automated blood pressures, it gives you a false reading on sometimes high and sometimes low. And if the cuff size is too small, you're always going to have higher blood pressure. If the cuff size is too big, your blood pressure will be lower. And some of the automatic ones, it checks, but then it goes halfway through and then it blows up higher. So that automatically gets your nerves and anxiety up and it brings your pressure up higher. So as a rule, you really want 2 or 3 consecutive blood pressures unless it's really, really bad to check. So that's what I really want to see. But remember, the blood pressure is the same thing too. High blood pressure leads to strokes. It leads to heart muscle thickening, called a cardiomyopathy, a hypertensive cardiomyopathy. It leads to kidney failure. Most people think diabetes is the number one thing that causes people to be in kidney failure. It's not. It's high blood pressure. The number one thing in the world is high blood pressure. We even have some 20-year-olds on dialysis now because high blood pressures have been running so high, even in their teens, and 10 years of extreme high blood pressure. Remember, after a while, your body gets programmed and your brain says it likes the blood pressure high. So you won't know it's running high and it's just damaging the inner organs. And those are inner organs we always watch out for, is the kidneys, the brain, and the heart. Now, the complication of hypertension, we just talked about the strokes, the kidney disease, you have vascular hypertrophy, I was telling you about in the arteries, but you also get it in the heart, and eventually can lead to a form of cardiomyopathy. Different hypertension drug, and they're changing every day. You have to tailor it to what your risk factor is. If you're diabetic, you should be on an ACE inhibitor, ACE receptor blocker. If you have your heart rate's really high, then you need something to control the heart rate. As a rule, when we first started, when we had these JNC 5, 6, 7, 8, and even 9, most people tell you to start off with a diuretic. It's difficult to start off with a diuretic. We made them change that. When I was at UAB, we made them change that from just listing it as a diuretic as the number one starting agent. Reason why, as we get older, most people don't drink enough fluids. So if you're dehydrated, so you get people with falls, dizzy spells, and we also get forgetful. We don't take the medicine as much. So we added then one of my favorite drugs is amlodipine. We added a calcium channel blocker to one of the first starting agents because it's easy to take and it doesn't dehydrate you as much. And they found later that it's a long acting drug. So even if you're late from taking it in the morning to the afternoon, it'll still kick in and take effect. But an initial phase is always a diuretic. And if the second drug is not the first drug is not a diuretic, then the second drug should be a diuretic. And that really helps. And usually there's low dose diuretics that's not as bad, and that's hydrochlorothiazide. In the past, we used to start off people with like 100, 200 milligrams. We found out that was not effective. So now we're down to about 12.5 as a starting dose. And that just doesn't affect. The problem with the hydrochlorothiazide, when you don't drink, some people get hyponatremic. That means the sodium gets low and you start having confusion. So if you're starting a new drug, you still have to see those people back. It's not one of those things I start them, I see them back in 6 months. No, it needs to start it, and you really need to see within that 3 month range, 6 weeks to 3 month range, is you have to check the blood levels. And you're checking